Welcome to Dr. Saif Critical Care Academy. My name is Dr. Mohammed Saif Khan and I am a critical care consultant. And this lecture we will discuss the use of high flow nasal cannula in ARDS. We will explore whether HFNC only improves oxygen levels, makes breathing easier and increases the patient comfort, or if it also leads to better overall results. Additionally, we will examine if using HFNC could negatively impact outcomes by delaying intubation and consider if we should depend on this treatment method. So learning objectives of this session would be quick understanding of physiological basis of HFNC, then the evidence base would be explored on its use in ARDS. More importantly, all of you should be aware of specific factors or predictors which govern HFNC success or failure, and finally we will discuss few practical decision making strategies for bedside care. So let's start. HFNC improves oxygenation and comfort through several physiological mechanisms which we are going to explore. So the first of all, HFNC can provide FiO2 up to 100%, and this is the major plus of HFNC compared to other non-invasive oxygen supports such as standard oxygen therapy, nasal cannula or face mask. Anatomical dead space is the volume of inhaled air that fills the conducting airways such as nose, nasopharynx, trachea, bronchi, but doesn't participate in gas exchange because it doesn't reach the alveoli, representing the wasted ventilation. So the dead space is the wasted ventilation, and in a healthy adult, this volume is roughly 150 ml, about 30% of a normal 500 ml tidal volume. And it serves as a physical space for air transport to gas exchange sites. So the continuous high flow of HFNC flushes this exhaled carbon dioxide rich air from anatomical dead space, replacing it with oxygen rich air, and this mechanism effectively increases the volume of each breath available for gas exchange inside the alveoli, leading to better oxygen diffusion and oxygen level. The high flow of gas creates a modest flow dependent PEEP effect, okay, so the positive and expiratory pressure, which can range from 2 to 7 centimeter of water, and which acts similarly to PEEP. This helps to prevent the collapse of the small alveoli at the end of expiration. So basically it improves the alveolar recruitment, increasing the lung volume available for oxygen transfer to the blood. Finally, HFNC reduces the inspiratory resistance. This is another mechanism. How? By matching the patient's peak inspiratory flow demand. HFNC reduces the resistive work needed to pull air through the nasopharynx. So, patient demand is very high because of ARDS, and that much flow demand will be given or provided by the HFNC, reducing the resistive work needed to pull air through the nasopharynx. And we have studies to prove this. So studies using esophageal pressure monitoring show that HFNC significantly reduces the inspiratory effort. So how do we measure it? By the pressure time product. As you can see here, this is the resistive work, and this has been shown to be reduced by up to 39%. You can just remember 40%. So up to 40% compared to standard oxygen therapy. So HFNC reduces the work of breathing by 40% compared to standard oxygen therapy, and you can see the improvement in clinical sign also, like reduction in respiratory rate and reduction in heart rate within hours of initiation of HFNC. So this is an important fact. Now another mechanism by which HFNC reduces the work of breathing is conservation of energy. So it improves the efficiency of HFNC in reducing the work of breathing. So what happens is that, as you know, HFNC does not only provide high FiO2 or high flow, it also provides the warmth, it also provides the heat. So active heating and humidification, typically to 37 degrees Celsius and 100% relative humidity, minimizes the energy the body is spent to warm up the air and humidify the air. preventing airway drying, desiccation, and improving mucociliary clearance. Now, what's the evidence behind the use of HFNC in ARDS? Let's explore the evidence. So the first evidence is very interesting. This is the major trial called Florali trial, published in 2015 in NEJM by Pratt et al. So in this landmark trial, there were 310 patients with acute hypoxemic respiratory failure, which were randomized to 3 groups. One group HFNC, another group NIV, and third group received standard oxygen therapy via face mask. And then they compared and they found that HFNC showed a trend toward fewer intubations. The patients who were on HFNC required lesser number of intubations, though this difference was not statistically significant overall. So in patients with PaO2 upon FiO2 less than 200, HFNC significantly reduced the 90-day mortality compared to NIV or standard oxygen therapy. Moreover, HFNC was better tolerated and less dyspnea and dryness was observed. Now, NIV was also associated with higher intubation rates compared to HFNC and worse outcomes in this population, possibly due to patients' self-inflicted lung injury. So, NIV was hazardous in this study, leading to more number of intubations and worse outcomes. So, now we have guidelines published by European Respiratory Society in 2022 on HFNC, and these guidelines emphasize its role as the first line therapy in acute hypoxemic respiratory failure. But these guidelines caution against prolonged use in moderate to severe ARDS. In mild ARDS it's fine, but in moderate to severe ARDS you have to be careful. Without close monitoring, it may be hazardous because the intubation will be delayed and it will overall worsen the outcomes. So guidelines stress that prolonged HFNC in failing patients increases the mortality and early intubation is safer. Now, for prevention of this hazard, the delay of intubation, a very nice index which we use is called ROX index. The ROX index is basically SpO2 upon FiO2, SF ratio upon RR. Okay, so ratio upon RR, this will give you the ROX index, and it was presented and discussed at ERS 2022 guidelines conferences as a validated bedside tool to predict the success or failure of HFNC therapy in patients with HRF. So they said that low ROX index score suggests potential HFNC failure, prompting early consideration for escalation to alternative ventilation methods such as non-invasive ventilation or intubation. Okay, so you have to escalate when there is a low ROX index, early hours of application of HFNC. Conversely, a high or increasing score indicates a higher likelihood of success, allowing continued HFNC use. So if the ROX index is high, then you can be sure that your HFNC is basically helping the patient and it will definitely improve the outcome. Now, we have meta-analysis. So this meta-analysis published recently, and from this meta-analysis we have a pooled analysis which show HFNC reduces the need for intubation compared with conventional oxygen therapy, though the magnitude varies by study inclusion criteria and illness severity. Mortality benefit is not consistent and often not demonstrated when restricted to adult de novo hypoxemic ARDS cohort. When HFNC is compared with non-invasive ventilation, results are mixed, and some analysis suggests that similar intubation rates but better tolerance with HFNC, while other caution that an IV may increase the failure in de novo hypoxemic respiratory failure due to high potential of PSILI, that is patient self-inflicted lung injury. So the safest practices. So now we will discuss what are the predictors of high flow nasal cannula, success and failure both. Okay, so there are some specific clinical and physiological parameters. Okay, so let's see. To be very simple, patients who are more likely to succeed with HFNC therapy if they exhibit higher ROX index, the ROX index more than 4.88. This is a dynamic predictor. An increasing ROX index over time, particularly a value of more than 4.88 at 12th hour after initiation, is strongly associated with success and lower risk of intubation. If oxygenation gets better, higher SpO2 upon FiO2 SF ratio or PaO2 upon FiO2 PF ratio. Both we can use nowadays, all right, SF ratio and PF ratio. So if ratio are more, especially an improvement within the first hours of application of HFNC, that portends the success of HFNC. If tachycardia is improving and patient maintains the hemodynamic stability during HFNC, that itself indicate reduced respiratory distress and better outcomes. Now what about failure? Failure often defined as need for escalation to an IV or intubation, and it is associated with three factors mainly: for oxygenation less than 100 millimeter of mercury of PF ratio, lower ROX index, persistent tachypnea more than 30 per minute, and worsening mental status because of respiratory acidosis, CO2 accumulation or CO2 narcosis. And even the need for vasopressors to maintain the blood pressure is a strong predictor of failure and higher mortality. So debate has been there about use of HFNC versus intubation. So we have two things. HFNC stabilizes the borderline patients. It gives you some time so that you can optimize the patient's lung using diuretics. You can try proning, awake proning in such patients, and you can probably give some sedation to reduce the respiratory rate and help them to comfortably breathing. And overall, it is a useful bridge in resource limited settings where you don't have the supply of invasive mechanical ventilators and expert help. In such cases, especially this has been seen in COVID-19 era, when we didn't have much of supply of nursing and hospitals equipped with high oxygen supply and the ventilators. So in such cases, HFNC really helped us in stabilizing and buying some time, and actually it improved the mortality and reduces the rate of intubation. But if somebody who requires intubation, and if intubation is delayed in such conditions, such patient who doesn't have signs of success of HFNC, then there could be a lot of issues like PSILI. So first, provide initial trial with high flow nasal cannula for moderate ARDS or mild ARDS. While patient is on HFNC, don't forget to closely monitor ROX index at 2, 6 and 12 hours, okay, and record it and monitor it properly. And escalate early if ROX is less than 3.85 at 6 hours or 4.88 at 12 hours. If there is worsening of gas exchange or mental status, better to intubate the trachea. It will prevent disastrous outcome in such patients. And finally, you can try combining HFNC with adjuncts like awake proning. As I said, it may improve or diuresis and restricting fluid and conservative fluids. So what you need to remember in exam is very important. The first, HFNC is not a definitive therapy in ARDS. It is a bridge. Remember, this is a bridge. It just buys some time and to the more definitive therapy. Knowledge of ROX index and PF ratio threshold should be known for early escalation to intubation or an IV. And HFNC does give comfort to patient. However, safety should never be compromised. And therefore, guidelines emphasize vigilance. You have to be vigilant while HFNC is ongoing. HFNC is acceptable, but intubation should not be delayed when failure signs appear. As you know, what are the predictors of failure? Now, here I will give you this case vignette, and you yourself ask yourself questions, and you can answer in the comment. All right, that what is your take on this presentation, this video? So key message is that HFNC is a double-edged sword. It can buy precious time in selected patient, but if misused, it risks delaying intubation and worsening outcomes. And second, vigilant monitoring and early escalation are the hallmarks of safe practice. So that's all. Thank you so much for your attention.